So like all good presentations, I wanted to start with a case. And this patient is sort of a combination of probably 2 or 3 patients that I've taken care of in the last year. It is a 30-something-year-old female coming in with back pain or shoulder pain or leg pain with normal vitals. So you pick up this patient, it's an exercise you're going to see on your shift, and you're super excited. You're thinking, I'm going to get this patient feeling better. I'll make sure it's not anything like threatening, and I'm going to clear them out of the department. But before you do that, you open the chart just to quickly get a little background, see if there's any history. And you see the past medical history. This patient has fibromyalgia, chronic Lyme disease, POTS, and chronic fatigue syndrome. And you look at their allergy list and you see all of the favorite drugs that you love to use to treat pain. It's Tylenol, it's ibuprofen, it's Toradol, it's Haldol, it's Dex, it's all the other steroids, including prednisone, it's atrazine, it's Benadryl, it's even the hand sanitizer that they're putting on you. This is a real patient that I've taken care of all the 2 times. Okay, how are you guys feeling?
Frustrated.
Yeah. Is anyone excited about this patient? Is it you? Is it you? Hassel, Willis? Excited? They are awesome. This is why they're program directors, because they are running into this just optimistically, ready to give the best care ever. Neutral people, hopefully we keep you at once. You don't have any strong feelings yet, right? Hopefully you've not been in this situation where you've had to manage a patient like this. And so you're going into it sort of fresh, excited. It's your first back pain ever. How many people feel bad starting this encounter? That was me. That's still me sometimes. When I start an encounter and I see a chart like this and I see a complaint of pain. And that bad feeling is what led to this therapy session, which I'm titling Triggered. And I focus in on fibromyalgia as sort of like the fundamentals of chronic pain and chronic pain discussion, but you can really kind of like extrapolate this to all patients that trigger you, and hopefully you learn some things along the way. So after sort of thinking about this topic and where I wanted to start, like all good therapy sessions, I wanted to start with something positive first. And I think about my favorite patients I take care of in the emergency department every day. And they're usually little old ladies. I love little old ladies. So this is kind of the same way that Hassel loves me. And anyone that's worked with me knows, like on every shift, I try to pick up like one patient that's the oldest woman in the room. And I see that patient and I hang out with them. I think Caleb knows. I like find out that they're like a jazz singer in some club nearby, and I like look at pictures of their grandchildren. And for me, that's how I like rejuvenate myself on a shift, because I love little old ladies. So I found a little old lady with fibromyalgia because I wanted to start with a positive case. Let's see. Hopefully this plays.
My name is Mary Ann Farrell, and I am a person with pain. I have fibromyalgia. So in my mind, I had 3 options. The first option was just go to bed, stay in bed. The second option was suicide. And I certainly would think about that. The third thing, I can only do one day at a time. Different medications were tried, different therapies were tried, some more successful than others. Doctors love people with fibromyalgia or chronic pain to exercise. Right now, I'm walking. That seems to be the best therapy for me right now, using my muscles and getting out and being in the fresh air, or on a treadmill when the weather is bad. I've been playing the piano since I was 5 years old. I use my music every day to help with my pain management. A few years into this pain life, I call it, I heard about the American Chronic Pain Association. I called and found out they were having a meeting, and it wasn't too far from where I lived. And for the first time, I actually was with a group of people that understood me. So I became more active in the group, and I was asked to start my own, be a facilitator for my own support group when I moved from that area. I help myself by helping others. I never even thought of that principle before. I was used to teaching people music, and I got a lot out of that. But teaching people about how to live in pain, that's what I do. in my support group. I teach people how they too can have a good life.
Okay, so this for me is like my ideal patient with fibromyalgia, right? This is what I want them to all look like. That's not really the reality. They're not all cute little old ladies. They're not always on a pathway that is successful for them in terms of managing their pain. They don't all have a lot of education about their disease process necessarily. And not all of them have found good strategies for how to take care of their pain. So for me, I've really never taken care of a patient like this with a chronic pain syndrome, not so far. A lot of the patients are very different that I've seen with this disease process. A lot of them are younger. A lot of them are angrier. A lot of them are more decompensated. And I started thinking about that. And leading into my next part of it, I wanted to look for, are there any similarities then between the patients I'm seeing with the symptoms and with this disease process and between me and them? And so the similarity parts, I think, sort of helped me put into perspective why I feel the way I feel when I look at these patients. So similarities, I look well, I hope. I look like a healthy person, right? I look like a young 30s to 50s patient that you would take care of that has no obvious visible signs of disease. And that's a lot of what the fibromyalgia patients that are taken care of look like too. They oftentimes look like young, healthy, oftentimes women, that's the demographic, who have no visible signs that I can identify as injury or trauma or disease, nothing obvious. Second thing, they don't trust me. They don't trust me because they've seen a ton of doctors, a ton of physician assistants, a ton of nurses that immediately meet them, hear their story, and they don't trust them. And I don't trust the patient. That feels really shitty to say out loud. Excuse my language. Let's just try to Great. I want to hear this stuff. I don't trust the patient. That feels really hard to say, hence my therapy session, right? It feels bad to look at a chart and say, are you really allergic to Tylenol? Are you really allergic to Benadryl? Right? But we think it. We don't trust the patient. We don't trust their story. We don't trust their history. We don't understand each other. I don't understand their diagnosis. I've heard a million lectures on CHF, on sepsis, on DKA. I've never really been to a lecture on fibromyalgia. And chronic pain, not really. I've listened to some stuff on like phone, but I've never really been to a good lecture on chronic pain. And then frustration, right? I heard someone call it out in the beginning when I asked, how are you feeling? So that's sort of mirrored in the patient. They're frustrated because they're in pain, they're unhappy. You're frustrated because you're walking into this encounter and you feel like you're not going to walk away satisfied. You feel like you're not going to be able to fix the problem to make the patient feel better. So that frustration is a shared similarity. So for this talk, quick, I want to just go through a little bit of background. I'm not going to spend a ton of time here. I'm going to talk about some science because I think that's another big part of therapy is increasing your knowledge about something to help sort of reduce those feelings of frustration that you can get when you encounter it. We'll go back to the patient for a little bit and discuss some of the clinical features, and then we'll talk about management, some approaches, some challenges, and finally, hopefully some tips you can add to your toolbox for the next time you take care of a patient like this. Okay, so in terms of background, in the mid-19th century-ish, you start to see some reports in France and England of patients coming in with pain that is sort of widespread and is not really fully characterized by any other diseases that they have out there. They titled this fibromyalgia. Thought process initially was that there was some inflammatory process driving this disease process, but as they did more research and looked into these patients and did lots of blood work on them and tried to look for elevated inflammatory markers and elevated CK, they did not find that. And so that sort of transitioned us away from fibromyalgia into fibromyalgia, recognized by the Society of Rheumatology in the 20th century. And this is more a non-inflammatory pain syndrome. And now we have some more new terminology, chronic widespread pain or CWP, which is more of a spectrum of disease and includes a lot of other chronic sort of like co-occurring pain symptoms. And so in terms of prevalence, which is sort of what these numbers are at the bottom, we're looking at like somewhere between 4 to maybe as high as 15% of the population in the US. And so we're thinking that maybe 5 million people somewhere. Okay, so let's talk about some science. What causes fibromyalgia? I have no idea. I did a ton of reading. There's a lot of like speculation and opinion pieces and like theories, but none of it is really validated. They have no idea what causes this disease, but we do have some information on what these patients have at a molecular and biological level that is shared along the disease spectrum. And so what they all sort of share is disordered pain regulation. And we'll talk about this a little bit more in the next couple of slides, but the underlying theme of that is central sensitization, which basically means that the way that their brain processes pain, they're very hypersensitized, they're very hyperstimulated. And that drives a lot of how they respond to painful stimuli. Okay, so first piece of science. These patients, like I said, have increased neuronal activity in the brain processing sensors that respond to pain. So when you look at functional MRI of patients with fibromyalgia compared to a control patient that does not have the disease, their brain lights up when you compare them with the same stimuli. So if I pinch a patient with fibromyalgia and I pinch a patient that doesn't have it, this is sort of the response you're seeing, that hypersensitive response. And this is a real finding. More science. They have a total reduction in their brain volume matter compared to patients that don't have the disease process, right? And so when you look at these patients, look at their brains, they are showing signs of premature aging. So their stated age is 35. On the outside, they might look like me. On the inside, they feel like they're 90 years old. And as you can imagine, that means that the way that they experience pain, the way that they experience sensations, and their cognition is going to be more similar to an elderly patient than to me and you. Okay, this one, not as much robust research, but there is some thought out there that they have a hyperactive stress response, and so they may have elevated cortisol levels in response to something that you or I may consider to be like a normal encounter and not very stressful. And this is not really as well studied compared to the other two things I talked about, but it's out there. And then, so the big thing that I wanted to kind of touch on in terms of like science here today is that the modulation of their GABA and glutamate neurotransmitter mechanisms is totally messed up. It's not like my neighbors, well, assuming no one here is around. And this is sort of like the fundamental thing that I wanted to kind of give you as a takeaway in terms of their treatment. And so we know that glutamate does excitation from a neurotransmitter standpoint, right? And GABA is inhibitory. And so understanding like what's going on in this transmission of pain signal is really helpful from a scientific standpoint to help you sort of like understand at a molecular level what's going on with your patient. And so quickly looking at this like very junky diagram, you have your pain receptors or nociceptors that release glutamate, excitation, right? And glutamate can now bind to NMDA or AMPA receptors and modulate potassium and sodium channels, and that can cause depolarization of a neuron that then propagates pain signals throughout your body, okay? And so hopefully that depolarization is happening appropriately in most of you, and you can propagate a pain signal appropriately, and then kind of react, your body can kind of adjust from there. GABA, which is more inhibitory, when that's released and binds to their receptors, this causes influx of chloride anions, and those hyperpolarize the cell. And so hyperpolarization is actually great because it raises that threshold that's needed for your cell to depolarize again. And so it's able to basically prevent you from like depolarizing over and over and over and over again, and experiencing that hypersensitivity, that increased pain response. And so when you have this functioning normally, it's great. When it's abnormal, it's implicated in a lot of disease processes. So high glutamate, which is what we see in patients with central sensitization, they're getting depolarized all the time. People with lower glutamate, that's implicated in schizophrenia, which is I think pretty interesting. It shows you a spectrum of disease that you can see from the same system. In terms of GABA, we talk about this all the time. A lot of the drugs we use, like benzos and bars, right, act on these receptors. When it's high, you have issues with neuroplasticity and recovery. And so you have a hard time basically getting your cells back to that baseline where you can sort of recover and heal. And when it's super low, that's when we think about our epilepsy disorders and anxiety. And so again, you can sort of see the spectrum of disease that happens with dysregulation of the system. Okay, great. So for our PGY1s, these are some of your favorite drugs that you're going to be using all the time. Does anyone remember like the mechanisms for any of these? Tylenol, how does it work? I think this was kind of a fun one to look up. I actually don't really know how Tylenol works. That's kind of crazy to me. Like we use this drug all the time, and it is just not really well understood. And so I think when I was in medical school, we were still teaching like cyclooxygenase with the enzyme that it acts on. Now it doesn't really seem like that's a primary mechanism for how Tylenol works to treat pain anymore. And it's more so for NSAIDs that cyclooxygenase works, right? So that's like your arachidonic acid from your membrane, and then that gets broken down with cyclooxygenase to make all the prostaglandins, and the prostaglandins can cause pain and inflammation and some other stuff. And NSAIDs sort of block that action, so hopefully reducing your prostaglandin synthesis, and it works really well peripherally. And so that's how we sort of get that anti-inflammatory aspect. But acetaminophen, we really don't know. This mechanism may be a little bit of cyclooxygenase, but a lot of others. Okay, what about antidepressants, TCAs, that stuff? Yeah, exactly. So they're reuptake inhibitors of serotonin, right? But at the molecular level, they're really going back to that previous diagram we talked about and the ion channels that are involved in essentially depolarizing your cell and hyperpolarizing the cell. And so when you increase potassium channel activity, you get postsynaptic hyperpolarization, which we said is a good thing, right? Because that kind of raises the threshold that's needed to get that action potential to go off and propagate the signals. They also can block the voltage-gated calcium channels in the presynaptic nociceptor, and so hopefully helping to prevent release of glutamate, which then can cause that like excitability response. Gabapentin, similar thing with the presynaptic membrane, that's sort of its like primary action. And so hopefully again, stopping that excitation process by hopefully modulating the release of glutamate. Opiates, when you get down to like the fundamentals of it, very similar, increasing potassium and chloride activity, so that's the postsynaptic hyperpolarization that you want, and blocking that presynaptic glutamate release to hopefully reduce that depolarization. And then finally, local anesthetics, lidocaine, we talk about sodium channels. That's what they're doing. They're blocking those. They're helping to stabilize the membrane, hopefully to make it more difficult for your cell to depolarize. And so when you think about like injecting local lidocaine, this is sort of the mechanism for how you're interacting with that local tissues. You're all going to need to know doses of these medications, right? And so that's sort of one of the like fun intern jokes that everyone makes, like, oh, what's the dose of Tylenol? I'm sure you guys all know the dose of Tylenol. But one key thing to remember is looking at these medications, you want to know contraindications to when to give them, right? So knowing what patient populations to use certain things in. And then for pediatric patients, whoever is starting on P, everything is going to be weight-based. So don't start throwing out like random numbers like 650 Tylenol for someone that's this size. It needs to be calculated by their weight. And I won't go too much into that now, but just something to be aware of. Okay. So when we talk about multimodal pain management, it's like a word we like to throw out in medicine. The reason why we talk about that is because all of these medications sort of act in different places, and your goal is to tackle pain from multiple points. So you want your NSAID action, if you can get it, for that peripheral inflammation. But you also want to attack things that go at the perception of pain, right? And so trying to do combinations of drugs, that's what pain management is. It's trying to basically get that ideal combination of drugs that attacks pains at different points. Let's get back to the patient. What are some of the symptoms and results that you'll see of failure of the modulation of GABA and glutamate in these patients? They're going to have widespread pain. They're going to have multi-site pain. It's usually in like at least 6 different areas, but they may have prominent spots. Maybe they'll have back pain a little bit more in one patient versus arm pain in one patient. Sometimes they'll have paresthesias, and so they may also have like numbness, tingling in certain parts of their body, and that's part of the same process. Fatigue is a big prominent symptom for many of these patients. Sometimes it's from a primary sleep disturbance like obstructive sleep apnea or restless leg syndrome. Sometimes they just don't get restorative sleep, and so they will tell you, I'm sleeping 10 hours a night, but I wake up and I still feel super exhausted. Cognitive disturbances, so you'll hear fibro fog. I feel like people are shaking their heads like, this is what presidency makes me feel like. Fibro fog, so again, these patients are having aging brains, right? And so they're gonna have some cognitive disturbances, and sort of have the sensation that they're not experiencing their environment the way you and I are. Psychiatric, so we talk about how, low GABA can be implicated, or low glutamate can be implicated in schizophrenia at one extreme, but many of these patients face depression, anxiety, and other psychiatric disturbances. Headaches is another common symptom you'll see, so they'll have migraines, sometimes it's tension type headache, but it's recurrent. And then other chronic co-occurring painful diseases, or like psychiatric diseases can coexist with this as well. So that's things like IBS, painful bladder syndrome, painful pelvic syndrome, chronic fatigue syndromes, temporomandibular syndrome, and a list of them. They also can have autonomic dysfunction. I didn't really see a lot of like the pathophys discussion for why, but don't be surprised if they also have things like orthostatic hypotension, tachycardia that come along with their disease process. Raynaud phenomenon, that like the cold, sort of cool extremities with the discoloration. However, they will not often have the thermographic and microvascular abnormalities that come with primary Raynaud's. Edema and swelling, a lot of the times these patients will tell you my legs are swollen and you'll look at them and you don't see it. But interestingly enough, they actually have alterations in their osmotic gradient of some of their fiber nerves that give them the sensation that they're swollen. So they're not lying to you when they tell you that they feel swollen or that they feel like they're edematous, even though when you push on them, you don't see that swelling. And then finally, in terms of timing, a lot of these patients, it's chronic. And usually, but not always, they've had other diagnoses excluded. So hopefully they've seen rheumatology, a pain management specialist, primary care, and had a workup for hypothyroidism and some of the other diseases that present with some of these symptoms. Okay, so let's kind of switch into management and challenges. I sort of like put together tips for myself, and I'm sharing them with you. First is make time. So they can sense when you're rushing, right? Patients can tell. When you walk into a room and you're already like, how do I get this patient out of here? How do I end this encounter right away? Sort of brace yourself, take care of other stuff in the department that are emergent, and just tell yourself that when you walk into this room, I'm going to be present here and I'm just going to have some time, and it's okay to dedicate that time to this patient. Set expectations. You want to talk to the patient early on, maybe not right off the bat, like establish a little rapport, but then set the expectation that today you are not going to get them feeling 100% better. And that's a tough thing to do. It's a little bit of a balancing act, figuring out how to talk to a patient and set that expectation. But you'll see a lot of attendings do it really well and observe those encounters and try to emulate that. Same for seniors. You'll see the seniors do it well also. Discuss. So a part of this talk for me was learning about the disease so that when I have a patient, I can kind of flex my knowledge, right? I can show them that I did some research. Just like when I tell my patient confidently, you have a pneumonia on your chest x-ray, I'm going to give you antibiotics. I want to have that same confidence when I talk to these patients about their disease, because it shows that you cared enough to look up their disease process and try to understand what's going on with them. In terms of some I's that I want you to remember, identify. Remember that they can have many, many symptoms. So actually one of the patients I've taken care of a couple of times with fibromyalgia at downstate, her prominent symptoms usually fatigue. Usually she's not sleeping really well, and it's actually not pain. And so you need to identify that first so that you can actually know what you're going to do in terms of intervention to make the patient feel like you're addressing the complaint that day. Investigate. So this is like goes without saying, right? Emergencies are still emergencies. These patients can have STEMIs, they can dissect, They can have any other emergent pathology that you're going to see in the department. And so you don't want to just sort of anchor on this is chronic pain, but always keep your mind open to the actual pathologies that could be there aside from their disease. Inquire. So that long allergy list, maybe you didn't open the chart and see it, and you just sort of ordered your reflex like Tylenol, Toradol cocktail that you do for everyone. A lot of these patients have been through this a bunch of times and they know what they want and they know what they don't want. So if you just assume that you're going to give your Tylenol Motrin cocktail and just send them out the door, that's not going to end well as an encounter for you or for the patient. Ask them, do you have allergies to meds? Have you tried other things that help you? I've had patients surprise me, tell me like, oh, lidocaine patches really work for me. I don't like Tylenol. Maybe it's not an allergy, but just a preference. Ask them. Oh, like trust but verify, that's my TBD, right? Like, ask them what they take, what they do, but then also look in the chart and see sort of what's been done for them before. And the last thing is impact. So our program is all about social determinants of health. And so you're always looking for ways you can impact the patient in that way. Remember that things can exacerbate their symptoms. So say they just lost a parent or a child, or they're recently on domicile, all those things are going to be happening in the context of their life and affecting their disease. If you find or identify something here, you can use that to sort of establish rapport with the patient and then also intervene by getting social work on board or whatever else that needs to happen to sort of make their patient care comprehensive. Okay, and then for 2 R's, reconciliation, polypharmacy is super important in these patients. A lot of them are on medications for their symptoms already. And the last thing you want to do is start throwing on a bunch of anticholinergic this, antihistaminergic that, when they already have things like beta blockers, opiates, benzos, antihistamines, and all that stuff in their med history already. So look in the chart again, trust but verify. Always try to figure out what are these patients taking in the long term. And then at the end of your encounter, think about referrals, sort of going back to that impact piece. If they haven't had a workup yet, or they've just been told they have fibromyalgia, but they don't have a primary care doctor or a rheumatologist or an expert that's sort of like managing their disease, try to look for ways that you can refer. And again, you're not like passing off the responsibility, but you're trying to make sure that their care extends beyond the person. Just for your awareness, there is an outpatient pathway for these patients that I think is nice to know. And so the first line that they always try, I remember our patient said, all the doctors love to tell her to exercise. And so oftentimes their management will start with non-pharmacological measures like exercise and education. So teaching them about the disease, teaching them about their triggers, and then cognitive therapy as well. When that doesn't work, they move on to pharmacotherapy. And the common ones that we see are TCAs, which is really helpful for their pain and potential mood disturbances. SNRIs are often used for depression, especially when combined with fatigue. And then when it's more prominently sleep disturbance, a lot of the times they're on gabapentin for that. And then in the last part of my talk to sort of wrap things up, I wanted to kind of throw this paper back out there. This is a paper that one of my co-residents that graduated last year ago used for his senior talk that I'm obsessed with. I love this paper. And I think all of you should try to read it. It's very short. It's a little bit outdated. It's from 1978 and some of the terminology is a little archaic and sketchy, but it still is very relevant today. So I wanted to sort of use this as a framework for talking about the challenging patient when the other things that we sort of talked about in the previous couple slides don't really work. So the first one is time. We talked about in the department, you don't have a ton of time. And the patient that this sort of rings true for me are the clingers. That's what they call them in the paper. I don't know if I like that word, but the clingers are the patients that have a self-perception of bottomless need. Every single thing is wrong with them. There is just no way that you're going to be able to address all the things, but they think that you will be able to do it. And so this is a tough patient because it's the one where you walk into the room and you're in there for like 30 minutes. And you walk out and you're like, I have no idea what just happened. I don't know what I need to do. I need to see like 4 other patients right now. It's rough. For these patients, you want to just admit your weakness early on. Let them know you're a human and that I'm sorry. You have 10 things going on with you today. I may not be able to address every single one of them. Let me start by addressing the first 2 or 3. Let them know that you have a limited resource in terms of your time. Right? Find a way to say it, but in terms of your time, in terms of your knowledge, because you're not the expert on this disease, and in terms of your skills. The next one that's challenging is the hostile patient, like hostility, right? And so these are the loudest patients in the department. We all will know when they're there. They're screaming, they're angry, they're intimidating the staff members in the area. They're threatening to sue you. They're trying to use guilt to sort of get you to do things for them. These patients are really, really tough. I think they're the ones that we immediately think about when we think about like our chronic pain patients, patients that we classify as frequent flyers. And the tough thing with these patients is they're trying, the feeling you get on the inside is that they're there to personally get you, right? It feels like they're attacking you. Like, you just came today to piss me off specifically. And that's not true, right? Even though it feels like it's true, it's not personal. The tip it gives for these kind of patients is share their anger, which I kind of like that. It's about finding some thread of similarity between you and them, and some thought process that's similar that they have that you also hold true, and then trying to like be in there with them on that. So Tylenol, right? How does it work? I don't know. That sucks. I agree with you. It really sucks that we're always giving you Tylenol and we don't even know how it works, right? So that's a way to sort of like go and flip the script on something that they're angry about. Or if they're pissed off that the hospital is really busy, that's an easy thing to flip on. I hate that too. Why is it so busy here? I cannot spend as much time with you as I want to because there are 20 other patients to be seen. That makes me angry too. You deserve the best care. You deserve to have a doctor that can sit with you for 2 hours in the ER, maybe not, and do good patient care even. So trying to find a way to sort of take their anger and like reflect it back on them in a positive way can potentially help. And avoid getting entangled though, like don't get too caught up in like their war, but finding something to share. Health projectors. So these are the patients that are kind of weird to me. Like they sort of have this pessimistic view that nothing you're gonna do for them is gonna make them feel better. But at the same time, they tell you right up front, they're not leaving until you make them feel better. So it's like, what the heck am I supposed to do? Like you just told me that everything that I could potentially try is not gonna work. Again, it's sort of a similar strategy for the previous patient. Share that pessimism with them and say, yeah, you've had this disease for 4 years and you have tried everything and nothing has made you feel better. And like within that, try to drop the hint of like, and also today I have not going to fix you feel better. And I agree with you, that sucks. But what can we try? Let's try to do this together and find at least one little thing I can fix that can make you feel a little bit better. They also have a fear of abandonment, these patients. And so this is sort of when you're ending that encounter, you want to use that referral piece to help them feel like you're expanding their care and not like just abandon. Like once you leave the ER, I don't care about you anymore. It's more of like, you're going to see my friend, the rheumatologist, and that's sort of like within the Kings County system, within the Dante system, you're still a part of the family. We are not abandoned. And then these are the toughest patients, I think, are the do no harm patients, the ones that we're trying not to do harm to, but they're doing a lot of harm to themselves. And so I think we all in our minds have a few patients that we can think about that we see all the time for a very similar thing. And it doesn't seem like they're getting any better, right? They always come in, they're hyperglycemic, they're in DKA, they're struggle busting it. There's just like, it's really hard because in these patients, I think in the back of our mind somewhere, we abandon them a little bit, right? We know they're here and we know we're not going to do anything to make them better. And we also know that they're not going to walk out and like do anything to make their lives better. And so the feeling is just like resentment, abandonment, like you're not gonna make it. And so for these patients, I think what's important is to fight that impulse to abandon them. I think it's something that I push myself to do every day when I pick up a patient that is a frequently seen patient in the emergency department, is try to fight that urge to say, oh, it's just another day, you're here again, I'm gonna give you some fluids, get your sugar down and get you out of here. And still try to screen them for those emergencies, identify their capacity in that day, in that moment, make sure that they're still able to make good decisions for themselves, whether you think they're good decisions or not. is one thing, but identifying that capacity. They could be having a psychiatric emergency that day. Maybe they do need to be put on a hold that specific day. Maybe they have a subdural, right? We'll always talk about the alcohol patient being your tumbler, and the person that the day you think it's just another intox is a day they're gonna have that brain bleed and you let them metabolize alcohol for an entire shift. And so let these patients remind you to be humble, but then also accept that this could be a terminal illness for them. And I think that's my favorite part of this paper is that sometimes this is a terminal illness. This will be the thing that kills them. It will be their opioid addiction. It will be their alcohol addiction. And that's really sad. I think the sadness is sort of what drives me to try to be a good doctor for these kinds of patients. So takeaways, just to sort of wrap this up, takeaways for me and for you as the physician, as the provider. Identify your triggers. That was a part of what this lecture was for me, was like, what's something that really kind of grinds my gear? And then give a lecture about it. Tell Esteban, he'll let you sign up for an extra lecture. Reflect on the why. Like, why does it trigger you? I realized for me, fibromyalgia triggered me because I didn't understand it and I didn't do any research on what it is. And now that I've learned a little bit more about it and thought a little bit more about pain and how complicated pain is, I feel a little bit less triggered. Address the deficit, so look it up, learn more stuff, try to identify things that you can improve in terms of your trigger, and then practice it every time you take care of these patients. And then in terms of for patient care, again, sort of calling back to those previous slides, make time for these patients, set expectations, and communicate that you understand their disease. In terms of like the pathophys or what's out there about the pathophys. And then use your eyes, so identify what your prominent symptoms are, investigate to rule out emergencies, inquire, and impact when you can in terms of social. And then finally, try to do a reconciliation for patients with chronic pain to make sure you're not adding polypharmacy that could potentially be harmful, and refer whenever you're able to get them sort of plugged into our system to get good care overall. All right, these are our references, and thank you. Welcome.